Glutamate and GABA, those are the last two of what we would call the major neurotransmitters, right? So Cassie, we're almost done with this. Glutamate and GABA, we're going to talk about the same stuff for both of those. So what are nootropics? These are drugs, or nootropics, as some people may call them. That's the same people who call it zoology instead of zoology, right? I don't know. There's always like that debate, right? Have you heard anybody call it zoology?
No, I've never heard
Really?
of say that.
Because you've just been in Ohio too long.
Never had my eyes dilated, but never know.
These are drugs that are going to improve your cognitive function, right? Again, we talked a little bit about how that might work on your cholinergic system, but there's another group that might work on glutamate as well. How many of you have heard of glutamic acid? It's an amino acid. Glutamate's basically the same thing, it's just been ionized, so don't worry too much about it. We already said that it's part of many proteins, so all of your cells are making glutamate, not just the ones that release glutamate. There's also aspartate. That's another excitatory amino acid, that's a neurotransmitter. Not as much work has been done on aspartate. Many of your glutamate receptors are also going to be sensitive to aspartate, but we don't typically think about those as much. Typically focus on glutamate. Not a big deal. Jason, this is sort of in line with your question earlier. Because all cells are making glutamate, neurons that actually release glutamate as a neurotransmitter should segregate that population of glutamate, right? So they've got the glutamate they need for protein synthesis, and then they have the glutamate they're going to release at the synapse, right? So they'll keep that separate population of glutamate. That's why we need to look for these glutamate transporters to make certain that it is a neuron that is going to release glutamate and not just one that is making glutamate for its other business, right? Because the only time you're going to release glutamate is if you put it into a vesicle, and you're going to need one of these 3 glutamate transporters to do that. There's glutamine, you're going to make glutamate, not a big deal. Talked about that. If you don't have glutamate transporters, these cause problems. If you don't have type 2, you're going to die immediately. If you've got type 1, probably live about 3 weeks if you're a mouse. If you don't have type 3, you're actually going to be completely deaf. Everything else is going to be fine. The reason for this, Kristen, is that
Just your ears.
Just your inner hair cells actually use glutamate, and they use specifically the VGlut3, right? They use that specific glutamate transporter. So if you don't have that glutamate transporter, your inner hair cells won't work. Everything else will work fine, but you're not going to be able to hear. So that's interesting. Jason, this is when I wanted to talk about transmitter co-storage, right? But we already talked about it, so we don't have to worry about it. Hey, remember that time I told you neurons release neurotransmitters? Well, I lied. Astrocytes do as well sometimes. But only glutamate, right? So we're only going to think about glutamate release, which is kind of interesting. Glutamate's very important. Glutamate is also very toxic in high levels, and you can actually kill your brain cells by releasing too much glutamate. I know, right? Sierra, you want to avoid that.
I'm gonna try.
So astrocytes will also take up glutamate, right? That's an important process. So they'll suck that up out of that extracellular space, so you don't have too much glutamate. Experimentally, you can create brain lesions by applying glutamate agonists, right? And increasing the release of glutamate, and it'll be a neurotoxin. I don't know if that got anybody excited. That was a small pun there.
Oh.
I know, right? Hang in there. Again, you've got transporters to pull these back in, not a big deal. If you don't have those transporters, it can cause problems such as seizures. That makes sense, right? This is an excitatory neurotransmitter. You release it, you don't pull it back in. Things are going to get too excited, it's going to cause a seizure. That can lead to brain injury and death, early death. That's a mouse having a seizure, in case you want to know what that was. Yeah, it's not, you know, doing flash dance or something. I don't know what's going on there. That was just for you, Jason. I'm just going to make a bunch of 80s jokes that no one else is going to get. Just for you. I've never seen flash dance. Was it any good?
I haven't either.
I wouldn't waste my time on it. I mean, I haven't wasted my time on it, so there you go. We already talked about astrocytes, not a big deal. Once they pull up the glutamate, they're going to convert it into glutamine, and then they'll pump that back into the neurons. You don't want to be transporting glutamate around. What if you accidentally drop that stuff? Well, then you've got a neurotoxic event, right? So you want to make it into something that's not active, transport it in a safe state, right? This is why, how many of you have ever transported dynamite? You always pull the wick out, right? So in case it doesn't catch on fire. That's not, Olivia, that's not exactly how that works, but you get the idea, right?
I mean,
Yeah.
it would make sense in the cartoons.
It would make sense in a cartoon, right? Assume you're in a cartoon and it works. This is that kind of process. We don't need to think too much about this, right? If you get really excited about this, have fun with it. But release the glutamate. We're going to suck up the glutamate, turn it into something that's not glutamate so we can transport it back over here, turn it into glutamate again and drop it down, right? We want to control that process. Not a big deal. You've got a couple types of glutamate receptors, inotropic again and metabotropic. You guys already know this stuff, right? So it's just a repeat here because it's a different neurotransmitter, right? In terms of inotropic receptors, you've got your AMPA receptor. AMPA is actually a sort of a synthetic amino acid analog. You've got kainate, that's kainic acid, and NMDA receptor, right? NMDA is actually sort of an important receptor type, right? It's involved in the consolidation of memory. We talked about ketamine and how ketamine interferes with the NMDA receptor, right? And that can cause memory problems. You guys remember that?
Mm-hmm.
All the non-ketamine users said yes. The rest of you, no. I don't know. So, your NMDA receptor, not a big deal. AMPA and kainate receptors, that's going to allow sodium to flow in. Yeah, that should say NMDA. That allows in sodium and calcium. The interesting thing about the calcium is it activates a second messenger system, right? Which is sort of how this synaptic strengthening and long-term potentiation occurs. You guys probably remember that from your physio and bio-bases courses, right?
Mm-hmm.
Let's assume you do. Did you guys talk about that? Really? That's disappointing.
Talk about anything. We talked about split brain like
Yeah,
every time.
hydrocephalus.
Yeah.
I forgot what that would be.
You talked about syphilis?
Hydrocephalus.
Oh, hydrocephalus. I mean, you could have talked about syphilis. I mean, that's a, right? I mean, that's a reasonable topic.
Water brain.
Oh.
Yeah, the water brain. That's
The big, the big head.
The big head. I
Yeah.
didn't even learn about it.
You got to put in the brain valve, right? So you can drain that off.
Yes, did. I don't know if you ever talked about how to.
That was a question.
It's like tapping a keg. You just put
How do you
it,
get the
put
water
it.
out?
You put it in a stent. I said, what's a stent? He said, I don't know. I don't remember that.
Hey, well, that's sort of what it amounts to. What are you gonna do? You like tapping a tree for maple syrup? You like that analogy better?
No, that's okay.
The thing about NMDA that's cool is it allows in, like I said, sodium and calcium. That calcium activates that second messenger system. What's really cool about this is when this guy gets activated, that secondary system, it's actually going to pull AMPA receptors to the synapse. So it's going to increase the number of glutamatergic synapses, or receptors at that synapse. So the next time you get a dump of glutamate, you get even if it's the same amount of glutamate, you get a bigger activation because you've got more receptors. Because in general, you will have more molecules of neurotransmitter than you do receptors, right? Each vesicle may contain 2,000 to 9,000 molecules of neurotransmitter, right? So if you drop off just a few vesicles, and you're already overloading the receptors that you have available, right? So if you can add more receptors, you'll get a bigger response. Not a big deal. There you go. There are your 3 receptor types that are inotropic for glutamate. They've got 4 subunits. That's not a big deal. You have different combinations of subunits. It does give you some sensitivity in the pharmacology, so you can attack different types of subunits with different types of drugs, right? Which is going to be nice. Not a big deal. Here's a drug called NBQX, blocks your AMP and kinase receptors. Okay. Causes sedation, reduced locomotor activity, ataxia. Does give you protection against seizures though, right? So that's something to think about if you don't want seizures. Talked about NMDA receptors. Not a big deal. These are always fun, right? These nice 3-dimensional things. They used to have these, there was like a whole series of this where they would present these like sort of like Magic Eye or Viewmaster diagrams. So you would have like 2 slightly different 3D versions, and if you crossed your eyes, you could actually see it in 3D. It was kind of cool. You see that a lot in journal articles. Not a big deal. For NMDA, you've got some magnesium that's blocking the channel. You've actually got to depolarize your membrane a little bit. You got to make it a little bit positive to kick that magnesium out. Once you knock out that magnesium, then you can do some things. There are binding sites on the receptor that are not for glutamate. For example, PCP and ketamine can bind to these receptors as well, which is kind of interesting. There are a couple drugs that are used for research and Alzheimer's disease they can block as well.
Can I ask another question? What does PCP
Like another one other than the one that you just asked?
Yeah. What does PCP look like? Like, is that a powder? Is that a pill? Like, how do you do that?
How do you do PCP, right?
Yeah.
It's a good thing to Google.
You should type that specifically. How do you do PC?
Do a PCP.
Wow, that.
I love when they mark different things into the pills. That is so interesting.
Really like the butterfly.
Yeah, like I've seen in the
The
one
dove.
drug book, they have like a Nike swoosh. Like, who would take a pill with a Nike swoosh on it? Like,
A lot of people.
not a lot of people
Yeah.
anymore.
Just
do it.
Like,
Duh.
Just do
Well,
it.
they have like all kinds of varieties they can put on there. Like, you think of anything and they'll stamp it on there.
Yeah, it's like you're making your own buttons, right? I mean, just stamp whatever you want in your pill.
I think
But
it's
not another game.
branding.
Then you'll get stabbed.
I think it is branding though, isn't it? Like, I feel like we've talked about that in class. Like, certain drug dealers put their little things in.
Yeah.
If you're buying the good stuff, if it has.
If you're Walter White, stand or whatever.
So how do you make it? Not that I'm gonna go manufacture.
She's asking a lot of
Nobody
questions about PCP.
talks about PCP, but then like every once in
It
a while, I
will
hear
ruin your
somebody on the
life.
news who's been like on it, and I don't know anything about this one.
Yeah.
It'll ruin your life.
That says what you need to know.
Really?
Guy tripping.
Do you want to watch this video?
Phencyclidine, also known as PCP, is a dissociative anesthetic that entered the market 60 years ago. When it first came out, it was a medical drug, but most of its use has occurred in non-medical settings. It functions similarly to dissociatives like ketamine, but it does have some unique qualities. First of all, every individual experience is going to vary, especially with hallucinogens like PCP. So, at most, I can give a general overview of the effects. Also, some of the effects, such as visual changes, time distortion, and thought alterations, could be good or bad. Among the positive effects are euphoria, stimulation, calmness, closed and open eye visuals, sociability, anxiety reduction, pain relief, and full dissociative experiences. The negative effects can include psychosis, confusion, body temperature disruption, paranoia, anxiety, aggression, nausea, vomiting, memory loss, seizures, coma, and decreased heart rate, blood pressure, and respiration. We've all heard horror stories associated with PCP. While a lot of the stories are false or exaggerated, it does have a tendency to cause aggressive or psychotic behavior when compared to other dissociatives, especially at higher doses. In one study, anesthetic doses of the drug resulted in agitation or hallucinations in up to 50% of patients. Also, drawn-out psychotic episodes have occurred in up to 15% of patients with anesthetic doses. Some of these psychotic episodes can last days beyond the original dose, though an extended episode like that is rare. At lower doses, such as what recreational users take, the psychotic episodes appear to be less common, but can still take place in a fair number of people. As far as we can tell, most of the truly insane reports of violent psychosis have generally come from those with a predisposition for violent behavior, meaning your mental state affects the experience. The effects of PCP really depend on the dose used. If you only take 1 to 5 milligrams, it's possible you may just receive thought changes, moderate visual alterations, stimulation, and a sense of calmness, whereas over 5 milligrams results in more unpredictable experiences that can include full dissociation, which can either be a good or bad thing, but it is certainly different than with the lower doses. Large amounts also have a tendency to cause feelings of impending doom. When smoked, the total duration is 4 to 6 hours. It begins working in 2 to 20 minutes and is strongest 1 to 4 hours after administration. I don't have as much information for oral use. The duration is reportedly around 6 hours as well, with an onset of about 30 minutes. PCP is an aryl cyclohexylamine. It functions as an NMDA receptor antagonist like ketamine, and it's also a D2 partial agonist, which could be contributing to its psychotic effects. The active levels of serotonin, dopamine, and norepinephrine can also be increased due to PCP's inhibition of monoamine reuptake. It also appears to increase dopamine and norepinephrine production or release. It's often said the synthesis of PCP occurred in 1926, and even good sources state this, but it appears to be inaccurate. Instead, a PCP intermediate called PCC was synthesized then, but not PCP itself. The drug's history begins in the 1950s when it was made by Victor Maddox at Parke Davis. Maddox created multiple chemicals, including PCP, and sent them to the company's pharmacology department for testing. This resulted in the discovery of PCP's anesthetic properties in 1956. By 1957, human trials were underway, and it was approved for use by the FDA in the late 1950s under the name Cernil. The drug was certainly a useful anesthetic, but Cernil was removed from the market in 1965. A large portion of patients experienced hallucinations, mania, and other negative effects, so it was no longer deemed ideal for human use. Recreational use largely began in the late 1960s in the US, and at first, much of the use was unintentional. PCP was sold as drugs like LSD, mescaline, and cocaine. The earliest use was found around San Francisco, but it quickly appeared elsewhere in the US, especially by the early 1970s. The substance was popular through the 1970s, but its use fell greatly during the 1980s, eventually becoming an uncommon drug. The mid-1970s is when a lot of the inaccurate, misleading media reports came out claiming PCP reliably caused things like superhuman strength. PCP had been a less restricted Schedule III drug, but the public perception of the drug contributed to it becoming a Schedule II substance in the late 1970s. Nowadays, PCP is a very rare drug. Inhalation is the most common route of administration, with oral and intranasal being less common. The doses for smoked and oral use are similar. A light dose is 3 to 5 milligrams, a common dose is 5 to 10 milligrams, and a strong dose is over 10 milligrams. Make sure to check your local laws before ordering or using PCP. It's a Schedule II drug in the United States. It's also legal in a number of other countries, including the UK, Canada, and New Zealand. The lethal dose of PCP is not known, but it's clear the drug can cause death. However, overdoses without death are far more common, and the deaths that occur tend to be connected to engaging in dangerous activities while on the drug. Overdoses can result in seizure, coma, and other issues. High doses that are more within the normal dose range, such as 20 milligrams, can cause dangerous manic states, sometimes featuring violence and aggression. You can minimize your chance of experiencing those states by sticking with a lower common dose. Another problem with high doses is acute rhabdomyolysis, which involves the breakdown of muscle tissue. This can contribute to kidney failure or kidney impairment. To minimize the chance of acute negative effects, PCP should not be redosed, taken regularly, or used multiple days in a row. Combining it with other hallucinogens or stimulants also isn't wise. Regular use is likely to disrupt memory function and can also contribute to depression, behavior issues, and abnormal thinking. Daily or near daily use comes with dependence. Tolerance develops quickly and will exist for around 1 to 2 weeks. Withdrawal may include some problems like depression and low energy. Neurotoxicity is a big concern with PCP, particularly if you are using high doses regularly. While this area is unclear and controversial, it is best to stack the deck in your favor by not using large amounts and not using it many times a week. If you have any questions about PCP, feel free to leave them in the comment section. You can also leave them in the Reddit thread for this video, which is linked in the description. Support on Patreon is greatly appreciated since it allows me to provide more drug education. If you want to help out,
Jason, what did Dr. Green say that the one girl took and then she never went back to how she was before?
I don't remember.
That
I
it was
remember her story about marijuana use. That's all I
Mhm.
So there you go, Cassie. Anything else you want to know about PCP?
No, but there's probably more drugs I'll ask you about, so.
That's the point of this class.
I have a question. Is tolerance forever, or is it just like for a certain period of time?
Well, I mean, it depends on no, it's just a certain period of time. Tolerance isn't going to last forever. You're eventually going to go back to your normal states, provided you can make it through the withdrawal period.
Is it like as long as you use it, your tolerance?
Your tolerance is going to
Stays
continue
that way.
to build as long as you're using, as long as you're actively, using the substance. You're not going to reduce that, tolerance mechanism you've created. Once you stop using, you'll try to, whatever mechanism, whether it's enzymatic or receptor, whatever mechanism it is that you're using to build that tolerance, those things will diminish over time, and then you'll go back to it.
Well, a lot of people overdose after trying to get clean.
It is,
Yeah.
because you'll go back and you'll think, hey, the last time I did this, it was this many milligrams, so that's how many I've got to use, not recognizing you've gone back to like a novice dose. Does that work? So there you go. Good questions all around. Metabotropic receptors, second messenger systems, not a big deal there. Got some autoreceptors. There are a lot of these drugs that work on those metabotropic glutamate receptors to help treat neuropsychiatric disorders. Not too big of a deal. There, again, you're not going to see a whole lot of folks probably that are taking glutamate drugs. We do want to talk about GABA, so I'm going to move through this fairly quickly. Here's a monkey, right? You could give it these drugs that enhance the function of AMPA, right? And that's going to increase their ability to do these delayed match to sample tests. So, it's kind of like increasing their working memory there, which is kind of interesting. I mean, those could possibly have some effects on folks who, are having some cognitive decline. Again, the results in humans haven't been that great. Not a big deal. Really, you're working with that long-term potentiation business and that activation of NMDA. If you can get that going, then you're going to be fine, right? You'll be able to remember stuff. That's going to be fun. You guys can read that if you want. This is that whole process of long-term potentiation. We'll just kind of slide through this quickly. So I was talking about bringing the AMPA receptors to the synapse so you have a stronger response later. Who told us that's how things work?
Oh, heck.
Yeah, Donald Hebb, right? He's the most famous Canadian neuroscientist of all time. You didn't know that, did you? There you go.
Thought he was Irish.
Huh?
I thought he was Irish.
I know. It's not. Not a big deal. If you guys want to read that, you can. Again, glutamate levels can be toxic. cause some excitotoxic damage, not a big deal. Causes cell death, that looks like fun, right? Not gonna worry about this too much. Here you go. How many of you eat shellfish? You should stop doing that. Right? Now they have this domoic acid that can cause lots of problems. Permanent loss of short-term memory. That's not good. Permanent loss of short-term memory. That's not good. Not a big deal. Don't worry too much about this. We've already talked about cell death. It seems like maybe excitotoxicity occurs in ALS. You guys are probably familiar with that, right? There are some drugs that try to drop that level a bit. Let's see. All right, so that's the end of the glutamate section. I would like to talk about GABA, because GABA is kind of interesting. You might see some folks who take drugs that affect their GABAergic system, right?
Is gabapentin? Is that what that is?
So gabapentin is sort of an interesting story.
If you're gonna tell me something terrible, I don't know what it is.
I'm not going to tell you anything terrible.
Okay. Well, last time it was like the ball shaking thing, so.
Yeah.
Well, Destiny was giving me that look, and I was saying I don't want to know something bad about it.
Yeah. No. Yeah. Gabapentin is similar to GABA. Works on those. Actually, it inhibits calcium channels. Again, hey, we're that part of Davis. Anybody ever seen that name before? Look at that picture.
Mm-hmm.
God, we just saw that on the PCP video.
You really didn't notice that?
I didn't either.
Oh.
Come on, guys.
Guys, nothing gets past you. Yikes.
That short-term memory.
It's on his damn plans.
Gotta watch out for that. So we want to think about GABA. That's gamma aminobutyric acid. Glycine is another inhibitory amino acid transmitter, neurotransmitter. We don't talk as much about glycine, but kind of keep that in the back of your mind that that's there as well. Actually, GABA is made from glutamate, so that's kind of interesting, by this guy called glutamic acid decarboxylase. You don't have to worry too much about that. There are ways that we can block the production of GABA. We're not really going to do that. Again, vesicle transporters, nothing surprising there, right, Megan? I mean, this is the same sort of we've had with every other sort of situation. There are drugs that enhance or elevate GABA levels, right? That works. Why would you want to increase GABA levels in your brain? If you want to shut it down. Why might you want to shut it down if you have epilepsy? Right? There really aren't too many other reasons why you're going to want to shut down brain activity, right? But epilepsy is clearly one of those times when you would want to do that. And so taking an agent that increases GABA levels makes some sense there. Doesn't make sense in a lot of other cases, but for for seizure disorders it does make sense.
So for the gabapentin, it's like nerve damage type dealio from like.
Again, we're trying to shut down. That's
That's
another
what I was gonna
example.
ask, yeah,
We're going to
so-
shut down the activity of that particular nerve,
Okay.
and so you're going to, you're not going to be sending those signals
Right.
that are like neuropathic pain. Yeah, that's one of the other sort of times when shutting down the activity of a neuron makes sense. Not a big deal. Again, we're going to pull up. We already talked about pulling stuff into the astrocytes. It's the same thing. Some of it's going to be turned into GABA. Not a big deal. Okay. Here's another epileptic or anti-epileptic drug, right? The problem with some of this is it also has side effects here. This particular drug will affect vision because it will sort of activate some of the intraneurons in your retina, which will shut down your visual inputs, right? So that's not good. They are good anticonvulsants. Hey Jason, GABA is also sort of co-synthesized and co-released with other neurotransmitters, right? In an individual neuron. That's exciting. I didn't know if you would have any questions about that. Just letting you know it's there. It actually is really cool. Sometimes you will release GABA and glutamate at the same time. That doesn't make a lot of sense to you. Perhaps like, why would I release something that's excitatory and something that's inhibitory? It's the same reason that your shower and water faucet has a hot water and a cold water control, right? You don't just turn on the hot water or turn on the cold water, right? You've got to turn them both on so you can get that nice fine-tuned temperature. And so you're going to release GABA and glutamate so that you get the fine-tuned firing rates there. Not a big deal. You've got a lot of stuff in your cortex hippocampus that are going to be GABAergic. Not a big deal. Right? Let's see what else you need to know. You've got different GABA receptors, A and B, ionotropic and metabotropic. We've talked about this story before, right? GABA A allows chloride to move into the cell. The more chloride you get in, the more you're going to, hyperpolarize that cell, right? The more negative you make it, the less likely it is to fire. We could talk a bit about seizures. Anybody see a patient with a seizure disorder? Yeah, a couple of you. Do you know what medication they're on for that?
So I saw mine today, and she was diagnosed with essentially a conversion disorder that makes her have seizures. Yeah. So
That's weird.
I can't remember what the technical name is called, but
Sounds exciting.
it's really weird. She has incontinence and stuff related to it, so it's to me it seems real, but I don't know.
Yeah. Well, have fun with that. Who knows? So you have seizures. GABA is going to be if you increase GABA, you're going to be less likely to have seizures. Not a big deal. Nothing really to think about too much there. Here's your GABA A receptor. You've got a slot for GABA. You've also got spots for benzodiazepines. There's some steroids that might bind there, barbiturates. You've probably all seen patients who have been on benzodiazepines, right? I mean, that's unfortunately a common theme. The problem with benzodiazepines is they're very, very powerful. They're really great if you're having a catastrophic meltdown. I don't know what the technical term for that is, but you guys know what I'm talking about, right? I don't think I have to use the DSM-5. The DSM-5 words for that. If you're having a catastrophic meltdown, a little shot of a benzodiazepine is a great thing. They are very fast acting.
Like a rescue drug? Is that what they usually call it?
I don't know.
I've heard it called a rescue drug.
That's quite possible. If somebody is so agitated, very agitated, giving them a benzodiazepine will knock them down quickly. Have any of you ever seen a benzodiazepine that's been administered? Like in action? No. Montana, have you?
Not like IV.
They work pretty fast, even in oral form, right? I mean, they're if you give them a decent dose, they can be. Some of them can be like just on the order of minutes. So we're talking about something that can be very, very rapid onset. They're not great choices for maintenance medications. You should try something else. I'm not saying that people don't need maintenance medications of some kind. A benzodiazepine is not that choice, and very powerful effects, especially in kids. I always worry when you hear about it. I always worry, how many of you have seen kids that have been on benzodiazepines brains. I mean, that's an unfortunately common thing. Well, good luck with that. Hey, here's another, man, those mushrooms. How many of you love mushrooms? I feel like they were just like
the. Yeah.
You can answer that as you choose, Jessica.
It's like the ones you can get in like a can.
Canned mushrooms.
You eat
That's
canned
tough,
mushrooms.
man.
Why do you get them fresh?
That's a lot of work and they go bad fast.
You just buy them bulk in a can.
Don't judge me. You need to be stocked on your mushrooms.
All right, so, well, we've learned something about canned mushrooms. But I just felt like there were like guys just like walking around in the woods like, hey, let's see what this does, take a bite. And then he was like, whoa, that was weird. And then the other guy's like, well, I'll try it. And of course, that's kind of how this process goes, right? I mean, interestingly, this particular mushroom was actually eaten by Siberian peoples because it gave them hallucinogenic effects, including macroscopia, which is when objects sort of appear larger than they really are. Which is sort of an interesting, like, I'm just imagining this guy in Siberia, like, sitting in his hut, and he's like, boy, I wish we could really, like, build on. And some other guy's like, hey, instead, eat this mushroom, you'll think your hut's bigger. And he does, and he's like, well, that was actually pretty effective.
Fun fact about these mushrooms, too, they're believed that the Viking berserkers, that's what they would eat before going into battle. Like, they're the ones that would run in without a shield, just wearing nothing but a bear pelt.
Yeah?
And that was believed to be, like, what would induce their battle trance.
Wow. That's pretty crazy. Yeah, that makes some sense.
No, that makes less sense. They're running in and everyone looks larger.
But if you look at
They don't have a shield.
I think they just like look at their own sword though, right? If I'm like,
You
this
just
is
stare
a
at your
giant
sword.
sword.
You have to be more badass because they're bigger.
Running into giant people with no shield.
That's not the only effect. There are other effects as well. Hey, there you go. They look nice too, right? No?
They're pretty.
I don't think you get these at Sam's Club.
You can buy them at Smoking Joe's legally.
Really?
I'm not going to tell you how to know that, but...
Well, that's fine. I mean, you know, good internet search, right? Figure that out. So there you go.
There's a lookalike, though, that's probably one of the most deadly mushrooms. The death cat.
Yeah.
Looks just like that.
Yeah. Yeah, you gotta be really careful on your mushrooms, right? No, seriously, you guys don't know this.
That's what I thought, the prettier they were, the like more toxic they were.
Yeah,
Like
that's
frogs.
That's a drama in nature.
Yeah.
That's not too many. Like really great things.
Now they get opposite effects.
Yeah, see, there you go, there's some mushrooms. Mushrooms can kill you. And they can give you some cool effects too, so. I'm not going to recommend you go out in the woods and just start plucking mushrooms and eating them. Learn what you're doing. You could go, we found this great website with these videos, and you could probably go there and get some information from Sean. Isn't that the guy's name?
Yeah.
Bicuculline is a antagonist for GABA. It blocks GABA A receptors, which is kind of interesting. If you do take this, it will give you convulsions. So there you go. That's not something you probably want to do. Some other convulsant drugs. You don't usually think about convulsant drugs, right? Like why would one give someone a convulsion, right? But picrotoxin is another one that can do that. Here we go. Benzodiazepines, right? And barbiturates, they actually potentiate the effects of GABA A receptors. I don't know if any of you have ever heard of ethanol, but that has similar properties. That's alcohol that you drink, not the kind you put on a cut. That's rubbing alcohol. It's isopropyl. You shouldn't drink that, Kyle.
Oh, my bad.
Just you know, that can cause problems. So, what do we want to think about with this? This is actually kind of brings up an interesting concept of like modulators, right? So some drugs that you take are not actually going to, by themselves, cause an effect. They will just enhance the effect of the neurotransmitter that's already there. You're still going to need the neurotransmitter, right? Some drugs will directly mimic a drug or mimic a neurotransmitter, but some drugs are going to be what we call like an allosteric modulator. They'll bind somewhere else and then enhance the effects of that when it binds. And benzodiazepines and barbiturates work that way. I guess barbiturates probably aren't. I feel like that's like a 1920s drug or something. I don't know that people do barbiturates much anymore.
Like Quaaludes, right?
I mean, some, right? I mean, people do, but I don't think I think other things are available now, right? And in some places, things are available legally.
Is a barbiturate what killed Michael Jackson? Is propofol or?
That's what killed him?
I think so. I'm just
What
curious.
do I know? You said propofol?
Yeah, because the Nicki Minaj song. What is it?
Let's see. Where's the action?
So is that why if someone's withdrawing from alcohol, they'll give them a small, like, benzo and like slowly back them off?
Yeah, because that's actually it's actually interesting because what happens when you take alcohol for a very long period of time, because it is a depressant, right? I mean, it's going to activate those GABA receptors. You're going to be reducing your sort of GABAergic system activity. And when you stop taking alcohol, it's like basically you've stretched a rubber band all the way down, and then you let go of that, and so then your excitation level jumps up. And if you don't have anything to ease you back into that, you can have like fatal seizures and stuff. Yeah, DTs. So you got to watch out for that, seriously.
You know, I saw that in the hospital the other day like that.
Yeah. Yeah, I think this is I'm trying to see, it does work on the GABA receptor there, Olivia.
It said Michael Jackson died of acute propofol and benzodiazepine intoxication.
Oh.
So I feel like if
So-
it was a benzo,
Yeah,
they would have just said benzodiazepine. So maybe it is a barbiturate.
so remember that time there was some guy who told you not to mix your drugs? The reason for that is barbiturates and benzodiazepines have different binding sites, and then you've got your GABA here. So you're just really overloading the system when you're doing it. That's why they tell you don't mix alcohol and barbiturates, right? Because again, it's going to be that same, you're overloading that same system, right? You should always, if you're going to mix alcohol with something like cocaine, you're probably okay. It's two different systems. Right? Makes sense to a lot of people, right? Tolerance, we talked about that. Not a big deal. Oh, there's propofol on the next slide. Talked about that. Diazepam, that's a big one, right? Okay, folks are on diazepam. I think is a fairly common benzodiazepine. Look at this. Let's see. This is sort of interesting. There are different subunits, right? And we've talked about subunits before. Different subunits are responsible for different effects of those drugs, right? So in this case, we're thinking about the sedative actions on the alpha-1 subunits, but the anti-anxiety actions are on the alpha-2 subunits, right? So here's the problem. If you're trying to treat someone for anxiety, you give them a benzodiazepine, you're probably also going to cause some sedation, right? But as we get better, maybe we could just target particular subunits with the drug. And some drugs we are getting better in some areas doing that. Oh man, who wants to talk about inverse agonists? That's kind of weird, right? Inverse agonists are kind of strange. They will reduce the effectiveness of GABA, so they're not, so that's kind of like an antagonist, but it's weird, but they're binding at the benzodiazepine site. It's a slightly different, don't worry about it. Don't worry about it. Oh, hey, remember that time I told you about allosteric modulation? Right there it is on the slide. Because I know some of you don't listen and you like to read instead. Remember that time you asked me if I read? I recommend you do the same. You've got some GABA subunits out in the hippocampus and the olfactory bulb. This is kind of interesting. So when you undergo general anesthesia, quite often you'll remember the things, you won't remember the things that happened right before that, right? Even before the anesthesia was administered, because we're going to screw around with that LTP process, right? Because we've not quite encoded those memories yet. They're still sitting out there in the hippocampus.
That's really cool.
It
That's
is.
like what people wouldn't remember, like a car wreck that caused brain injury. Too.
Right, absolutely, because it's going to predate, because you've got that memory kind of spooled in the hippocampus, and if there's anything that disrupts getting that into your cortex for long-term storage, you're not going to remember it.
That's right. You know that little rat thing? Where you toss it in the. You know what I'm talking about? Drug rat.
Drug rat.
No way. That little rat thing, you toss it in, it tells you about how the drug works.
Yeah.
Oh, meth mouse.
Meth
Yeah.
mouse, yeah. They talked about that's why like THC people say it messes with memory because it interrupts the long like the short term thing.
Yeah. So there you go, right?
Meth mouse, you learn it all.
I'm finally someone finally got excited about something in class.
Just meth mouse.
Just meth mouse. Just meth mouse. Was that from like Arizona State University, maybe?
Something.
Probably.
University.
It's like you pick the drug, like a rat on different drugs. And,
Yeah.
yeah.
It's informative though. Like it
It's a
tells
little-
you where it's binding, why it's doing certain things.
It does give you a lot of information. I've
Two
seen
ones
it.
looks like it.
And it's cute.
It's a mouse, right? You don't have to worry too much about neurosteroids. There's another baclofen. That's another muscle relaxant, right? That works. Also antispastic, in case you're having some spasms, right? And people have back spasms. Sort of an odd response to that.
I was just thinking Destiny was going to say Josh is going to spaz.
Apparently that's not true.
GABA receptors, we already talked about that. Any questions about GABA? Really the only thing you're going to see somebody taking GABA receptors for sort of clinically is going to be